Hello everyone, my name is Waksman. I'm from Washington DC. With me, Dr. Chevalier from Paris, Steve Ellis from the Cleveland Clinic, and Renu Virmani from Gettysburg from CVPAT. So with that esteemed panel, we're going to discuss today about drug-eluting stent. For introduction, the issues that we're going to discuss is what are the safety of the current DES. We'll talk a little bit about the incidence and the risk factors of stent thrombosis in the second generation DES, and what should be the optimal duration of DAPT in the second generation DES. Then we'll discuss a little bit about the clinical outcome across the different DES. Are there any differences between them, including clinical trials, which would be Resolute All Comers and Platinum, which are the most recent one, and a little bit about future directions in terms of technology, clinical trials, DAPT, etc. I think we do have to recognize that stent thrombosis was a major issue of the first generation DES, and this was a continued hazard of about 0.6% per year by the Bern-Rotterdam group. It's been published, but I think what's striking that this is not an ending story, and it has been shown, we reported even up to 7, and there are up to 10 years events of stent thrombosis. So I may want to pause here and ask Dr. Virmani, give me an explanation. Why do we see stent thrombosis still in first generation DES, although we don't use them anymore, but we still have millions of people walking with those. Why do we see it, and what should we tell those patients? Should be worried or not worried?
I mean, it's still worrying in the sense that they keep on occurring. And from our data, it looks more as if it's neoatherosclerosis. And as you know, bare metal stents also have events, but they occur very late after 5 years or 10 years. So I think in drug-eluting stents, as we showed, that neoatherosclerosis occurs within 2 years and then keeps on increasing as time goes on. And so I think that's probably what is likely caused. The other one that can be is that you could get an erosion, severe narrowing, focal severe narrowing without atherosclerosis and de-endothelialization because of shear stress, high shear flow. And that could also be a mechanism.
So Steve, you implanted many of those. You were also a principal investigator of the Taxus, I think 5, or one of the complex Taxus. So when you see patients in the clinic that walking up with Taxus today, and this is, let's say, 4 or 5 years out, what do you tell them?
Well, it's a good question, Ron, and I think there's probably no single answer. I think, unfortunately, that's probably the worst of the first-generation stents, at least that made it to market in the United States. I think most data would suggest that Taxus is somewhat more risky with regard to late stent thrombosis than Cypher, and certainly than second-generation stents. I think that the current data would suggest that for simple lesions, a single stent in a fairly large vessel, that we're quite safe at 12 months to stop the APT. I have some reservations, though, in the more complex lesions, the bifurcation lesions in particular, but I really don't know that answer, I think, specific to the Taxus stent at this point for complex lesions. There are some people that think perhaps that people should be on clopidogrel forever, although that certainly carries a risk too. The randomized trials would suggest that a year is fine, and perhaps even a shorter duration is all right, but I have some particular concerns for Taxus stents in complex lesions.
And Dr. Chevalier, in Europe, your experience with a very late stent thrombosis, first of all, is that something that you see on your practice, or you just read it on the papers? Because you also have a very busy practice. Are you actually seeing those very late stent thrombosis, so this is all people that were followed very thoroughly?
Not really. In fact, my practice was mainly dedicated to Cypher in the early days of usage of DES, so I don't have a real experience with Taxus. And I think it's like differences between the two platforms in terms of very late stent thrombosis.
Thank you. So again, we have to compare between the different stent thrombosis. Now we have the ARC definition, and when we look at definite stent thrombosis and we compare them between PES, sirolimus, and everolimus-eluting stents, they are different. And it looks like, rightfully, Steve, you're more worried about the paclitaxel because you can see that there is a different hazard ratio for paclitaxel compared to sirolimus, 4.4% versus 2.9%. And EES, I think, represents in this slide the endeavor, not the endeavor resolute, which was 1.4%. Which brings me to an interesting study that was done in Europe. It was called the examination trial, looking on EES versus BMS for STEMI. So now we're moving to patients who present with STEMI, and you can see here that when you're looking on stent thrombosis, the everolimus DES was 0.5 for stent thrombosis, definite stent thrombosis, and for bare metal stents was 1.9% stent thrombosis. And the definite and probable also was lower for Drug-Eluting Stents versus the bare metal stent, 0.9 versus 2.6. So again, Renu, I always hear you saying you should not place those stents on a necrotic core when you have a STEMI. And here it looks like that the DS in the ES form is safer than the bare metal stent. So any explanation and any change in recommendation?
I think the second generation certainly is better. If you look at the amount of drug on the everolimus-eluting stent is half almost the dose of what is on sirolimus. So it's not surprising in a way that it's doing better than what the first generation did. But what surprises me is that the bare metal stent is not doing as well as the everolimus. So for me, that's a surprise. Now, could it be, the differences are double, almost double. So it's for me a little scary that bare metal stents are not doing so well. So why is it bare metal stents are not doing? One of the things could be, as they are saying, that the polymer actually prevents thrombus from occurring, and so that it is a resistant polymer, that it's better than having a bare metal. So that's something to think about.
Yeah, I mean, I would concur with that because for the bare metal stent, the 1.9 is very similar to what we've seen in Horizon AMI. I mean, that was a similar rate. So this is concordant with the prior data. And as you mentioned, although it was not tested prospectively, and we were surprised to see this, there are some features in the PVDF polymer that are baby protective for stent thrombosis. So again, from the clinician perspective, you have a patient with STEMI today who comes to the lab. Any consideration not to give him today drug-eluting stent versus bare metal stent, or you would default all your patients to everolimus-eluting stent knowing this data?
I think, first of all, I always hesitate to draw conclusions based on one relatively small trial. But having said that, the network meta-analysis also suggests that the fluorinated polymer, lends some safety, additional safety. So I think that's probably the most reasonable stent based upon current data to use in the setting of the STEMI.
Yeah, but Steve, you're a very conservative individual, so I want to get from you a statement that unless the patient, for whatever is the reason, cannot take DAPT, there is no reason to consider any more bare metal stents for STEMI patients. Can you support that statement? It's a very aggressive statement.
It is an aggressive statement, but I think based on the available data, I would have to concur.
Yeah.
But if you look at the primary endpoint, it was not different.
Yes,
Okay.
But we're talking right now on the main issue that we are concerned, which is stent thrombosis, because we know that it's a bad thing, especially in the context of an acute MI. So, Bernard, in Europe, what's the ratio of BMS versus EES for STEMI patients?
I think it's still lower than for non-STEMI patients, and we are around 50-50 DES, BMS, with a current penetration of approximately 70% of DS in other cases.
And the guidelines, the European guidelines, say anything about drug-eluting stents?
European guidelines say that it's a default strategy to use a DES, except if the patient has a contraindication for long-term DAPT. I think it's clearly the question. It's always difficult in daily practice to assess really the capacity of the patient to comply with long-term DAPT when he arrives directly in the cath lab. You don't know exactly the story of the patient, and this is the difficult part. I think this is the reason why the penetration of DES is still lower in STEMI patients.
Yeah, I would think that eventually we'll probably see, we are very conservative, And we're still feeling under the cloud of the fear of the stent thrombosis that was presented in Barcelona. But I think over time we'll get over this fear and we'll move. I don't see a reason why to use the BMS today, unless it's a financial issue or someone that you know for sure he's going to a surgery and have to stop the Plavix relatively short.
But so today you do have this concern, economic concern, at least in the United States, since not everybody...
Maybe more in Europe because the austerities. But I think, look, we're spending so much resources. The difference in pricing right now between a DES and the bare metal stent in the US is $500 per stent. So it's not like huge as it was before. But we mentioned the APT. So the ACC, AHA, SCAI 2011 guidelines for the APT is it has to give in for at least 12 months, and it's a class 1 level of evidence B. In the case of high bleeding risk, either discontinuation left to 12 months of P2Y12 inhibitor therapy is reasonable, and then it's a class 2A, and then continuation of the APT beyond 12 months may be considered in patients undergoing DES implantation, and that's class 2B, level of evidence C. So my question briefly, as we move forward, we're all using now second generation DES, should we continue to adopt those recommendations that were not based on clear data? They were like a hint from some studies that were available at that time, but not a randomized study. There is a lot of push to shorten the duration. What is your kind of feel on what should be the duration when we're dealing with the second generation DS that seems to be a little bit safer in terms of the...
Well, I think, first of all, that you have to make a distinction between treating a patient with stable angina or ACS, because the ACS patient deserves at least a year of DAPT. But for the stable patient, granted, we don't have the data from the DAPT trial yet. We have 4 randomized trials that in aggregate seem to give us a signal that 6 months is at least as safe and probably even safer than 12 months. So I would have to say that based on the available data, I would argue that 12 months is possibly not appropriate. And we also have single randomized trials for the Endeavor stent, for instance, that perhaps 3 months is sufficient.
So let's look on the risk factors of stent thrombosis. Bifurcations, hazard ratio of 2.1, low ejection fraction, stent diameter, and then we have DAPT interruption less than 30 days, renal insufficiency, and total length of the stents. So Bernard, when you taking into consideration the duration of DAPT, what is the main thing that guides you clinically right now with the second generation? How do you tell the patient how long he should take right now the DAPT in general patients? I'm not necessarily the ACS patient, the stable patients.
Yeah. For ACS, we of course prescribe for 12 months. For stable patients, it's usually 6 months. And in some patients with high risk of bleeding, we reduce the duration of DAPT to 3 months. But clearly, we have to consider the patient as a global patient, not only as a coronary patient and not only as a stent patient. So it's we have to consider presence of absence of diabetes, the diffusion of the disease, presence of atheroma on carotids on the lower limb. So I think it should be customized. There is no real rule we can apply to all patients.
So you believe in personalized medicine?
I think so, yes.
Yeah, I think we're changing more to not being by dogmas, but going to...
Yeah.
Let's review an interesting effort that was actually published by S.J. Park and his group, which was the DES late trial. It was composed of actually 2 trials, the RELATE, which was a study that included a broad population of 1,625 patients who had received any DES. And then there was the ZEST late, which was receiving patients who had participated in the ZEST trial. So altogether, there were about 2,701 patients in this who were free of MACE with dual antiplatelet therapy for at least 12 months after DES implantation. And in this trial, there was a randomization between patients who received clopidogrel and aspirin and patients who actually continued after 6 months with aspirin alone. And as you can look at the primary endpoint, we are seeing actually that there was no differences between these two approaches. You can go with the aspirin alone versus the aspirin clopidogrel, and the event rate was the same event rate. Also, if you look at the Prodigy trial, we see when you're comparing 6 months versus 24 months, there was actually no penalty in terms of stent thrombosis or in terms of death, MI, and stroke. So I'm presenting those trials because I think there is more push right now to go down to the 6 month. I think that this is the question whether we should adopt it or not adopt it. And my comment on that one, and I want to hear what Steve and Bernard has to say. We're running the DAPT trial in the US, and that goes all the way, I think, to 36 months. So suppose we find out it's with first generation DES, it's mainly clopidogrel, but suppose we find out that 36 months is better than 12 months. Aren't we going to feel stupid that we're cutting the duration now to 6 months? I mean, or you don't think it can even happen?
I think it's possible. You raised the issue that the makeup within DAPT is a mixture of stents, and at least I think as the trial was originally configured, the idea was they weren't going to break out the results individual to each stent, which makes interpretation of the trial, I think, a little bit challenging. Now, perhaps that's changed, I don't know. But there are 4 trials because in addition to the 3 that you showed, there's an examination trial, and they all point to the fact that, at least for the typical patient in the trial, the shorter duration is better. Now, I do think Bernard's absolutely right that you have to individualize, and so it isn't one size fits all. But I guess I would be surprised if DAPT comes out that way. But I think that the optimal therapy is both patient dependent and stent dependent, and DAPT has to separate that out.
But if you look overall, dual antiplatelet therapy has been shown to be effective even if you don't put a stent in a patient. So patients who have coronary artery disease is unstable patients. So they have lesions otherwhere.
But it didn't show in stable patients. It was shown somewhat in charisma on the unstable patients. So it is, let's go even further, because you do have an indication in Europe for interruption of the DAPT when you're placing the EES stent, the Zion stent.
Yeah. For EES as a 3-month CE mark. On
for interruption.
For interruption. On the Resolute as 1 month CE mark.
So is that changes your selection of DES when you're using it in the lab? I mean, is that make you feel any different because you have this labeling in?
Not really. I think the CE mark is not so well protective in terms of legal medicine. So I think it's a limited impact on. I think people are not so convinced about the 1 month indication for Resolute. I think the data are relatively weak.
And Renu, do you think that there is a protective effect on the vessel if you're taking long-term DAPT? Because there is a price to pay. There is also bleeding rate. So if you have to balance between the risk versus the benefit for a patient who has atherosclerosis, I'm talking about the stable patient, would you say, for example, I have patients that come to me, they don't have any issues to take DAPT. So should I tell them you can keep it forever? Or do you think it's going to be any benefit? Because I don't want to give them the drug if it doesn't do any good, just because there is no...
I mean, I think it'll be very hard to show benefit. When your incidence of repeat revascularization is only 6% or 10% maximum, and you'd need thousands of patients to show any difference. So I think it's going to be always empirical what you feel. I think it's a young patient who can tolerate, and he has acute MI, I would put him on dual antiplatelet therapy. If I was myself the patient, I would definitely take it more than 12 months.
Okay, so we beat the topic for death. Now we're going to DES versus DES, head-to-head trials. I usually hate them, but companies are doing them for different reasons. In this case of Resolute all-comers, it actually was done as part of the design to get a PMA approval in the US. So Resolute all-comers, comparing Zion's 1,152 patients to Resolute 1,140 patients. Follow-up shows for the target lesion failure, the lines are identical, 8.3 versus 8.2. There was no difference. If you look on Platinum, again, this is a head-to-head trial to get approval. This is like the new design in the US. You have to go in what is considered to be the leading market. And again, comparing the Cobalt Chromium EES versus the Platinum Chromium EES shows no difference at 24 month, and I think there was a data that was presented all the way to 3 years, no differences between the two. So what do you make out of all those trials? I mean, do you think they are necessary, or can we go after a benchmark? Why do we have to compare it all the time to, why don't we do an OPC, Steve?
I think that the event rates are quite dependent on the patients that are being treated, and it would be challenging to, I think the confidence limits on OPC would simply be too wide to be meaningful. So I think these trials, when there's a significant advance or change in this platform or the stent itself, I think they are necessary.
So you would support continuation of this strategy of comparing every news?
I think so, but what I don't like, quite honestly, is the size of the trial and the duration. Because you presented Resolute all comers, which actually suggested a difference in stent thrombosis. If you remember, the other trial randomizing the same two stents, 20, showed the reverse.
Yes. And in Platinum, 2 years was showing some advantage of the Platinum Chromium over Science. Now goes 3 years and there is no difference anymore. So a lot of this is subjected to marketing, and we have to be careful and knowing the limitation of those studies. A very good point. Now we're moving to in-stent restenosis. So Bernard, you were running a big trial. First of all, clinically, this is still a problem within the second generation DS. We see that the TLR rates is so low at 1 year and 2 years, and even in this meeting we just heard a late breaking trial looking on 2 years follow-up again between the Science and the Promus element. Rates are like 4% of TLR at 2 years. So is that an issue for a clinician to deal with in-stent restenosis in Europe? Or let's start with Europe, because you're seeing a lot of...
No, I think it's a real issue. Of course, it's few patients, but these patients are difficult to treat because clearly the recurrence rate in these patients is higher. So we are selecting a high risk of population. So I think we should definitely find a better solution than what we have today. And we know that balloon angioplasty is not working so much in this kind of patient, particularly if it's a diffuse in-stent restenosis. Probably it's better to use a new DS, but you are putting a second layer of metal. And the result of drug-eluting balloon are not so clear today in DS restenosis. They are clear in BMS restenosis, but not really in DS restenosis. So clearly it's still a concern, and we need to find a best solution. We need more data and more randomized data.
Yeah, and we don't have drug-coated balloon in the US, so I still do brachytherapy, believe it or not. Yeah. But this is interesting, looking on diffuse versus focal ISR, because I think they behave differently. On the focal type ISR, small numbers, 90 patients, that tells you it's very hard to conduct even studies like that. You have Cypher Select versus cutting balloon, and the diffuse type ISR, Cypher Select versus Science V. And you ran much more robust studies, but overall, if you look here, Cypher for the focal was better than cutting balloon, and Science was better than the Cypher for the diffuse ISR. I don't know what to make out of those numbers because these are such a small studies. So I would recognize that studies are existing, and I would agree with what you said. If you have very diffuse in-stent restenosis, this is very hard to treat. I would not recommend to put another DES. I think surgery is an option probably that will take care of that. Yeah. If not, brachytherapy. Okay, and that's also another study. It was ISR Desire 3, looking now to paclitaxel eluting stent and paclitaxel eluting balloon and balloon angioplasty. So maybe, Bernard, you'll share with us your experience with drug-coated balloon. Is this really used in Europe for the treatment of ISR? I mean, we're saying that we don't have it in the US, but how much this is being used, and is there any reimbursement on that, and is it really solved the problem?
It's used in Europe. There is no reimbursement for it, but it's used in Europe in this indication. Of course, as I said, there is not so much strong data. And here we have equivalency in this trial versus Taxus, but Taxus is not the best approach for this kind of patient. So clearly we need better data, and I think industry has to really organize a strong and large enough clinical trial, randomized of course, for proving the benefit of this technology in this indication. I'm not sure that paclitaxel is a good drug again in this situation. And Some,
in this study that was the ICER Desire 3, you saw that the paclitaxel-eluting balloon was much better than Taxus. But you argue, why did they pick even the Taxus when you saw before that actually science was better? So I'm just, don't know. I mean, I know why they picked the Taxus, because they wanted to use paclitaxel against paclitaxel.
Yes.
But I think it is effective for bare metal stent, as you said. It's less effective for DES restenosis, and it's less effective when you have a very diffuse ISR. But right now, it's probably the best tool that you have in Europe, because I think still it's better to do it than to put another DES.
But I have a problem with DCBs, especially with paclitaxel. Almost all of them, at least the ones that are available in Europe, have some emboli. They do embolize distally, and we've shown it in the animals, and if we can show it in animals, I'm sure it occurs in human, if not more. So my concern is, why should we be using these when we have stents which do just as well? I think Zions would be a perfect example to do it. Why put a Taxus?
So this is very interesting, because again, I'd like to make sure I understand your statement. If you have a patient with in-stent restenosis, and I have now two choices, to put a Zions or to put a drug-coated balloon, which one would you recommend me from the pathology perspective?
If there is only one stent previously used and not, multiple stents, of course. If there are already two stents, I wouldn't put a third stent in.
Sure.
Now, if there's one stent, I think it's all right to put a second stent. You can, especially if it's a large vessel.
So you would feel more comfortable with that than to do a drug-coated balloon because of the particulates that goes down.
Particulates bother me in the myocardium, so that's my reason for not doing it. And I don't like paclitaxel. It's uneven distribution. You're going to have some areas healing, other areas not healing. You're going to say, oh, I don't need dual antiplatelet therapy for too long. I don't know what you're going to do clinically.
And I have a sense that clinically that's what most Europeans or even around the world are doing. They're putting another drug. If you take the totality of all the patients with ISR, I'm pretty much thinking that the majority are still treated with another DES rather than with drug-coated balloon. Is that?
Yes, I think so. I think if we have a diffuse in-stent restenosis, I will prefer to use a second DES if there is only one, as you said.
Is there only one?
But of course, if we have already two layers, I think it's definitely a good indication for drug-eluting balloon, because we don't have better.
You don't have a choice.
I'm still convinced that it could be an interesting place for bioabsorbable DES.
Ron, we're making this a little too simple, I think, because at least the data, as I understand it, suggests that in-stent restenosis is mechanical in close to half the cases.
Yes.
And I think that we're looking only at the neointimal response. And to me, when somebody has restenosis, I think it's incumbent to do some extra imaging generally, unless it's obvious by angiography, to make sure that stent is not underexpanded.
Yeah, that's so true, because if you have stent fracture, I think you want to fix it with another stent.
Yeah. But, it's not only one of the things that we just did a paper, hopefully it'll get in, looking at what are the causes of in-stent restenosis and drug-eluting stents. What we found was the uneven distribution of struts plays a very important role. So putting another stent in is not a bad idea. And also is the extent of injury you do. If you really injure the hell out of that vessel, you're in trouble. You'll get, no matter how good your stent is, it's a limitation of stenting.
Okay, we move on. Again, this is an interesting paper, was published in the New England, just came out, comparing second-generation DES that are better than bare metal stents and first-generation DES. I think we all have an agreement with that, and it's true for zotorolamus and everolimus. So I think among the ones that are approved right now in the US, do you see any difference in terms of efficacy or for that statement?
I think globally not, although there are some mechanical differences that make me perhaps want to choose one over another in certain anatomic situations.
Fair enough. So let's move to bioabsorbable stent. Is that really the future? Radial strength is question. Need aggressive lesion preparation. Deliverability is not so good. Cost is expensive. And the long-term clinical outcome is in doubt. So Bernard, you have it available. It's in the market. Maybe not. It's also in France?
Not in France.
Not in France. You're always behind. But if that would be the case now, if this was on your shelf, because it's going to get to you before it's going to get to us, will you use it? When would you use it?
No, I think it's a good question. In France, it's not available because we have a specific pathway for reimbursement and we need randomized data. And so far, there is no randomized data with bioobservable DS. This is the reason why I think so far what we know that it's bioobservable DS is making the same thing in the first 2 years, 3 years than the DS. So we have kind of equivalency. But of course, there are some drawbacks. You mentioned the cost, you mentioned the deliverability, which is true in calcified lesion. And you mentioned also some uncertainty about radial force. So clearly, in my mind, it's a good tool for young patients.
Yeah, here's some data on the angiographic, which is similar at 2 years to designs, but again, this is not head-to-head trial. This is just an exercise that you take the patients.
These were the pristine patients with single vessel, with very short lesions, not severe lesions. So
Renu, is that going to be something that you think going to dominate the stent field, or it's going to be a niche product?
I think early on it's going to be a niche product. Now, if you can improve them and make a huge improvement, like magnesium stent probably can be improved enormously.
So we're coming almost to the end, but Steve, you're the co-PI of the Absorb 3 and 4, right?
4. Well, yeah.
If there will be the 4, but 4 is depending on 3. Are you concerned that on the 3, which is the non-inferiority at 1 year to Zines, you're not going to meet the endpoint? I mean, is there some concern based on some signals that you see from Extend or the other way around? You're very confident that that could be the case, that you're going to meet the non-inferiority?
I don't see any meaningful signal at present to suggest a dramatic difference in the first year, but I think there's a certain hazard, and it's not a sure bet that when you do an adequately powered study, we'll be able to show non-inferiority. I think there is some doubt about that. Principally, I think related to the strut size and perhaps a risk of thrombosis. But obviously, or not obviously, if we can show non-inferiority, I think there's considerable hope that down the road, long term, we'll hopefully be able to show superiority. But these are open questions, and I don't think that the answer is known right now.
It's only a 2-year study, isn't that right?
No, this one is going to go to 5 years.
But it is going to go for 5, but I think...
for the approval 1 year.
Non-inferiority at a year.
At a year.
Non-inferiority.
Yeah.
I think, if you look at the data which was presented on first 500 patients that were non-randomized, just registry, their target lesion revascularization is 10%.
It's close, yes. So I think we have to be really looking carefully on this study, because remember, this is also the first generation, but there's a lot to come, so a lot of exciting news. I think we are fortunate that we have now second generation DS, so we feel much more comfortable. Even our pathologist feels more comfortable with that.
That is correct.
But we're not stopping here. We're moving forward to new technologies, and there is also the biodegradable polymer on DS. So thank you, panel. It was a great discussion, and hopefully we'll all can repeat it next year.
Thank you.
Thank you.
Yeah, smile to the camera. And we're done.
I think